It is incredible what has happened here, and we are so thankful what they've been able to do to support Ontarians for the last year and a half and continue to do for all of Ontario. The pandemic highlighted for all of us what we can do together when we unite under one provincial system, utilizing all of our resources effectively to tackle issues where and when they occur. As we turn our collective attention toward our surgical recovery needs, we will build on what we have learned and apply that to what we know will be required in the coming weeks and months. This resumption of the healthcare system will almost certainly lead to an increase in referrals and impact our waitlists. Given the surgical recovery will have a system-wide impact, we've been working with partners across the continuum of care for a system-wide response. As stated by the Minister, together we have developed a comprehensive surgical recovery plan that anticipates the demand on our surgical care system and has a focus on finding innovative solutions to the way surgical care is provided. It's important to note that we are not out of the woods yet with respect to the pandemic. Throughout this initial phase of surgical recovery planning, we will closely monitor volumes and wait lists and adjust our plans as necessary, ensuring we have a lens on providing equitable access. With the additional government funding provided, we are fully committed to doing everything we can to support the expansion of care and service to patients needing care. As we continue on our path to reopening, I certainly encourage all Ontarians to seek the care they need, including their preventative screening care. With that, thank you so much, and I'll hand it back to the Minister.
Thank you very much, and we would be happy to take any questions. Thank you.
We'll go to the phone lines. Just a reminder, one question, one follow-up. Over to the first question, please.
Your first question comes from Matthew Bingley with Global News. Please go ahead.
Hi there. I'm just wondering if you can actually put a number to how many people are still in that backlog. And you mentioned the fact that you're expecting more people to come back. Can you just explain a little bit more about what that means? Are these people who are afraid of coming to the hospital and perhaps put off a diagnosis?
Yes, Matthew, we do know that in some cases people were not going to hospitals for routine care. They weren't going to primary care. We've seen a big increase in virtual care, but of course there's other preventative steps that people need to be taking that that just didn't happen during the course of the pandemic. So we want people to go back to receive those diagnostic procedures, mammograms, pap smears, other preventative tests, and making sure that if they need to have a CT scan or an MRI scan, that they go to receive those scans. So we know that there are going to be some people that will come forward that just haven't been diagnosed yet, but that's why we're building up our capacity so that we can deal with the people that we still have on the list and the people that we anticipate will be coming forward.
Follow-up?
Yeah, I'm just wondering how much in peril this plan is if there is a surge in cases in the fall.
This plan has been very carefully thought out, relying on the medical experts and people who know how to anticipate these volumes. We are prepared for an increase in the fall. That is why we've taken these steps to put another $300 million plus into the plan to make sure that we can get those increased volumes of surgical procedures and tests done. But for more particulars, perhaps I could turn it over to Matt for further comment on that.
Thank you, Minister. The only thing I would say further is just echo the Minister's comment that as we've been doing our planning, we do, COVID is still here, and we still need to have the resources to manage it. With the success of our vaccine strategy and the other tools that we've been using, right now COVID is at a manageable level. We'd hope that it will stay that way through the fall and into the winter. We can tolerate some increase. Obviously, we don't want to go back and little to do really even with the surgical recovery. None of us want to go back to the situations we were in the previous waves. Because of the steps that are taken, we're trying to avoid that and hope that that will not occur and have an impact on our strategy.
Next question.
Your next question comes from Jeff Gray with the Globe and Mail. Please go ahead.
Oh, hi, thank you. I just wanted to clarify the money. The 21 budget mentions $300 million for the backlog. So is this a plan that tells us how you're spending that $300 million that was in the budget, or is this an additional $300 million, making the total $600?
No, this is the original 300 with more added to it, of course. It's over 341 million, but this is to explain how we're going to deal with it, what we're doing in terms of increasing volumes, being able to do another 67,000 procedures on top of what we normally do, and also to ensure that we will be able to do the diagnostic procedures, MRIs and CT scans, and make sure that we're going to be able to deal with reducing the backlogs that we have, because now that we're into a recovery plan and trying to get things back to normal, then we want people to come forward for the tests and procedures that they would normally have had.
Follow up?
Thanks, Anna. As a follow-up, the FAO report in May kind of had its own projections and saying that the government needed to spend a lot more than that to address the backlog. Can you address, and maybe Matt could too, the difference between the FAO's projections and what you're actually seeing and the amount of money you put in now?
Matt, would you like to start, and then I'll have some comments as well.
Sure, thank you very much. So the report there is all based off of, as I understand it, is all based off of modeling from looking at what was the procedures from 1 year versus the next year and using the delta and then extrapolating that out over a number of years. That's my understanding of how the math was done. So I can only comment as far as that. I would say that what we're looking at is through the model that we've put together, it's really about understanding what our actuals will be. It's difficult to look in the rearview mirror to understand exactly what those numbers are going to look like. What we've got right now is a commitment from our government at the funding levels that you've just heard, and then we're going to work with our hospital partners and the other parts of the healthcare system to ensure that we can respond as these numbers become actuals and we see this occurring in the system. Where those numbers will go, we'll see over the coming months. I will say that Minister Elliott has been great in supporting us in that if there are adjustments need to be made, we will make those adjustments, but that part I will let her comment on.
Well, thank you, Matt. And yes, what we're looking at are actual volumes of surgeries that need to be done rather than the modeled numbers. And so some of the modeling may have double counted. People may have had them in several different lineups, so that those are not the numbers that we're working with. We're looking at the real numbers of actual people on wait lists. And that does make a difference in terms of the timing, of course, and how long it would take to deal with those numbers. So we are making a very concerted effort to deal with the real volumes of numbers of people that need to have these surgeries and procedures. And that's where we're investing the money, so that we can make sure that whatever it is they need, whether it's a hip or knee replacement or cataract surgery, whatever it is, that they will get that in a timely manner.
Next question.
Your next question comes from Natasha McDonald with Radio Canada. Please go ahead.
Hi, Minister. Just bouncing off of the previous question, how long is it going to take to clear the backlog? Like, how many years are we talking?
I think it's difficult to put an exact timeline on it right now, because there are some people that are going to be coming forward that just haven't been diagnosed yet. So we are dealing with the backlogs of people that we have now, but there will be more people coming forward that will need help after they've had some of these routine procedures that they might not have had for several years. What we are doing is working through this in a really organized manner with the money that's being put in. First of all, that's a huge increase in the number of surgeries and procedures that we're going to be able to perform. But we're also doing it in a regional manner so that we can have regional wait lists and make sure that we use every hour of surgical time that we can. So that if one hospital, for example, has a huge backlog of orthopedic procedures, and I know several do, that the surgeons may be able to work at other hospitals, and then the surgeries that one hospital might not be able to do for orthopedic surgery, maybe they have cardiac ability to do cardiac surgery. So we're really working in a very collaborative manner. Hospitals are working together in a way that I don't think has happened recently. And they've done that because, first of all, of necessity dealing with COVID, but now they're finding that it works for all of their patients and that this is a way that we should continue operating to make use of all of the resources that we have available to us.
Follow up?
Surgeons, health experts, they're telling us that their nurses, their staff are dropping like flies, that they're burnt out, that they've been, working flat out since the beginning of the pandemic. So hospitals can clear OR space to ramp up surgery, but how are they going to do this if they don't have the staff? Can you explain in further details what the plan is for that specifically for human resources?
Well, first of all, I think it goes without saying how grateful we are to everyone on the front line that's cared for COVID patients and other patients over this last very difficult period. All of us know that they have really worked themselves to exhaustion. And so it's going to be really important for them to take some time to have some vacation with their families, to have some downtime. You cannot expect people to continue working at this pace forever. So we are very conscious of that, and we are bringing forward supports from other places. We've got some nursing students who need to work to get their hours to be qualified, but some of them are also able to work in hospitals in order to relieve some of the other more experienced nurses, so they fill in at areas that aren't in intensive care, because we need those nurses to get some time, but we need to do that in a very careful, cautious way to make sure that the people that have been on the front lines get that respite, and that we fill in with people that are well qualified to serve at the level that they're serving. But perhaps, Matt, you could explain, you're more specifically involved with this on a daily basis as to how this is happening to ensure that staff get these breaks.
Sure, thank you very much, Minister, and thank you for the question. And this is our number one challenge as we think about the system and recovery and catch up and all these wonderful concepts, is supporting our healthcare workers. And I just add maybe a couple of comments to what the Minister has already covered. One really important one is that, and it relates to a comment that I made in my opening remarks, it's not just the hours that people were working under, it was the stress levels that they were working under. Let's get our OR nurses back in the OR doing the things they love doing, that they're trained so wonderfully to do. And you immediately start to bring the stress levels down. And the same can be said for all of the folks throughout our healthcare system. So really, that's a key part in getting people back into their routine, getting them back doing the things that they love to do, and that'll make a substantial difference. Combined with, as Minister Elliott said, the tremendous support that we've received from our government. And I do want to do a shout out to Minister Elliott, that when we looked at the recovery planning, she made a priority that we do not try to increase rate of surgeries through the summer and the early part of the fall, so that people would have a chance to do that. And that came direct from Minister Elliott on that. And so that's what we're trying to reflect through our plans. There's more work to be done. I do not want to make it sound like this is a simple challenge. This is a big one. We care and respect all of our healthcare workers. Their wellness is top priority. There's a number of things that are outlined in the briefing, and a number of things that Minister Elliott said, and I suspect there'll be a number more coming as we work with the field to identify other strategies that we can do to support our healthcare workers going forward.
Next question.
Your next question comes from Holly Mackenzie-Suter with Canadian Press. Please go ahead.
Hi, I just wanted to return to the question about the actual backlog and the volumes that you're talking about that were kind of used to build this plan. I haven't seen a number yet of what is the actual number of people waiting for procedures that kind of went into the planning here. And just wondering if you do have a figure that you can put to that to kind of help us understand what the health system is tackling right now.
Matt, perhaps you would be able to supply that.
Absolutely. Thank you, Minister. No trouble at all. So I'll throw a little bit of math on the tables so we can see what we're talking about. So right now on the wait list that we track across the province, we have about 200,000 people on those wait lists. The challenge that we have is that number would be largely the same if we look at our pre-pandemic levels. So this is what Minister Elliott is referring to on, it's not so much about looking in reverse, it's about looking forward. This investment is in anticipation that we will see more people coming through. And why we would have a number on our wait list that would be relatively same as the number that would have been there prior to the pandemic is that the referrals that have come through, so at the beginning of the procedure, you have a number of steps that you need to go through, including, and in particular, a number of diagnostic procedures. All of that has tailed off, or much of that tailed off, pardon me, through the pandemic. In fact, the rate of referrals has gone down at pretty much the same rate that the surgeries were reduced, which is what gives us this sense of equilibrium. Minister Elliott quite rightly points out that is not a level of comfort for us. We know that we've seen that reduction. We should be anticipating that we're going to see an increase in demand in care. Putting a number on that, I know that that's from the previous questions on this sort of stuff, very difficult to do, and rate and all those sorts of things. It's about getting our system back online. This is an investment by the government to get us ready so that we will be prepared for that. And then as that emerges in actual numbers as compared to retrospective analysis, we can then make adjustments as we go to see if there's places where we need to invest more, move resources around, that sort of thing, which Minister Elliott was referring to earlier in this talk.
Follow up?
Yeah, thanks for that. And I also just want to follow up on the staffing question, because we do have these programs to recruit nursing staff. I'm just wondering, you know, what is the target? How many people do you need to have working to reach this increased capacity goal of 115% potentially by the fall? Like, how many people do you need to have employed, and how close are you to that right now? Like, how many need to be hired before the fall, and how are those programs going?
Minister, would you like me to make a comment on that?
Yes.
Great. So I don't have a number handy for you. I can ask the team to follow up with you on that. I would say that overall, the idea here is if we are able to shift focus over to our surgical path and get these things back online, there's a number of items that are outlined in the press release in terms of some techniques that we want to follow to try to relieve some of the pressure. At the same time, it really is about focusing people back on the jobs that they love to do, they're trained to do, and trying to leverage through that. I'd also make the comment that there's a few of the procedures, I think about cataract, hip and knee, et cetera, that can be done at a very high rate for catch-up purposes. And so that, again, is something that we're working with the field to understand how might they be able to do that, perhaps even exceeding a 10 or 15% increase in throughput because of the nature of those procedures and how we may do them. So those are all different factors that we have to account for as we think about how we're going to meet the demands that are coming our way.
Last question.
Your final question comes from John Woodard with CTV News. Please go ahead.
Hi there. Thanks for taking the question. I noticed you were talking about things across the healthcare system, and I wanted to bring up one of the other big impacts of the pandemic, which is the deaths from toxic drugs and overdoses. I'm wondering if there's any part of the recovery on the healthcare system that's focusing on those increased deaths, whether that's ramping up some of the protections or raising the cap on the supervised injection sites.
Yes, thank you very much for the question. We did make an announcement about that several weeks ago. We have tragically seen an increase of deaths by overdoses or by toxic materials being contained in substances that people are consuming. So we are making investments along the whole continuum of care, I guess I would say, from what is being provided at the consumption and treatment services site, helping to make sure that people, if they're ingesting drugs, are going to do so safely there without an overdose. But we also want to make sure that there's harm reduction availability, that people will be able to be provided materials at health centers, consumption treatment services, and so on. We also want to make sure that we can invest in more RAM clinics, and also to help people if they are interested in withdrawal from drugs, to make sure that we can help connect them to the services that are available to them, because it's not a really well-connected system now. There's lots of supports out there, but sometimes people need to have someone to say, you need to move from this section to the next section. Not everybody is going to need the same supports along the way, but we're also investing in residential supports, both for young people as well as for adults, because we know that some people do require residential treatment, others do not, but we are making a significant investment there because we know that unfortunately, these fatalities are increasing. So investing more in mental health and addiction supports is equally as important in investing in physical support. So we are taking action on both, but thank you for the question.
Follow up, and this is the last question.
My only follow-up would be just a clarification. Is there still a 21 cap on supervised injection sites in the province?
There is, but there's still some availability. So any municipalities that are interested in having a supervised consumption treatment site are able to apply and to go through the process. So there is still that availability for any municipality that wants to become involved with one and have one in their municipality.
Thanks, everyone.
Thank you.